Welcome back to our Bloomberg Focus. I am Mary Berg Godwin, and I have a friend of the show here, Steve Brady. He's back, the CEO of Tempest Therapeutics, joining us today again.
Thank you for having me.
I loved our last chat, so I'm glad to have some more time to drill down and hear what's new with Tempest Therapeutics. First, your ticker symbol TPST, and so you're a clinical stage oncology company,
yes,
Tempest Therapeutics, and I know liver cancer is the primary type of cancer that this main drug that you're focusing on. So TPST 1120 now has a new name.
Yes, it does. Amezalpat.
I was going to try to say it, but I'm glad you said it first. Amezalpat.
Should be easier to say than a lot of the names out there.
Amezalpat. Amazing Amezalpat is what we're going to call it. Okay. So last time I believe I spoke with you, we were in phase 2, or you were in phase 2. And so where are we now and what's been going on?
Right, so technically we're still in phase 2 because even though we released the data that were received really well, as a reminder, we did what you consider a gold standard, right? A randomized study. We took our drug, combined it with the standard of care, and we compared it to the standard of care. And the reason everyone was so excited was because it beat it soundly in every category and didn't add much toxicity at all, which is, again, is always one of the goals, right?
Yes.
If you want to move the needle for cancer patients, you want them to live longer and actually have a quality of life. So adding on a whole bunch of toxicity doesn't make sense. So that's the phase 2 portion of the development of Amezalpat in liver cancer, because you made an important point. That's the focus, but that's not the only place this drug could go. So where we are now, and this is very important in drug development, so we took those data and we went to the FDA. Which
is a scary thing to do, right?
Absolutely. Absolutely.
That's like the, oh my gosh, what's going to happen?
It is, because you get together and with a whole bunch of people who have done this for many years, have developed, tried to develop multiple drugs, or been successful in some cases, and you think, I'm going to go forward with something. This makes a ton of sense. I think the FDA will agree with me, and I think the Europeans will agree with me, and I think the Japanese, because remember, this is global.
Right.
We have to take what we're doing with the FDA and go around the whole world with this. But the FDA is your big initial mountain to climb. And I have to say, just to be fair to them, because the government always gets a lot of grief, I worked in oncology most of my career. The oncology division of the FDA have been great overall, because we have the same goal, right? We're trying to get drugs to patients that balance benefit and risk, right?
Yes.
So we went to them with a proposal, and it was scary, and it was a wonderful set of conversations, very constructive. Granted, we didn't go in with anything crazy. We went in with what you call the gold standard of getting a drug approved, which is overall survival. That's going to be our endpoint. We went in with saying, hey, we're going to take this, add it on to standard of care and compare it to standard of care, basically taking our phase 2 and enlarging it, making it bigger so you can get all the math, right? You need statistical significance to win. That is one of the most rational ways to develop a drug. We didn't ask for shortcuts. The only thing we asked for could end up shortening things significantly in a phase 3 is we said, look, if this does really well, and we hit what you could call early efficacy, that is where we look earlier than the end, and you say this is working, can we end earlier? Can we file to get drug approval? And they agreed.
This might be way too in the weeds, but how long does that take, that process of you present it to the FDA and like an actual presentation in a boardroom or something, and then they think about it and assess the information? How long does that take? Absolutely.
So it's funny because I don't get that question very often. It's a process that takes months. We put together what's called a briefing. We ask for a meeting. They say yes or no. They can say no. They can say do Zoom.
They can? Wow.
Yeah, and they could say, let's just we don't need an in-person meeting. We can do this, or let's do Zoom. They actually said, feel free to come to the East Coast. We'll meet in person. We submitted then what's called a briefing document, which is, in our case, was close to a 100-page document with all of our arguments. This is why we think this is good for patients. This is why we hope you agree with us. And our initial reaction back from them was, largely, we agree with everything. Great. There's a few more things we want to talk about. We said, okay, we flipped it into a Zoom meeting because we said, we're not going to fly to the East Coast if we're and then the last meeting was great. And then they give you what are called minutes. And that's what you live by, your meeting minutes. And it's another big document that says, these are the things we discussed.
I mean, I don't know why that's fascinating to me, but I just, the process of getting it, because it's rigorous, and it's rigorous,
and they're being careful. Yeah, they're being careful, and they should be. Their job is not to let things get out into the market and get to patients that weren't carefully thought through. And we should want them to do that.
Right. And then it probably makes you think about things you didn't think about before.
Absolutely.
With just under 1 million deaths a year globally, the threat of liver cancer creeps up on us every day. A disease that thrives off obesity and alcohol consumption, finding itself a home in a society made of fast food and alcohol ads. It's causing a storm that together we must be prepared for. However, it's not just the disease we need to be wary about. The cure can be just as sinister and brutal. What about the quality of the patient's life too? How much suffering is extra time worth? Join us as we find out, what is this disease? How are we treating it now? And most importantly, who is doing something to make it better?
I think obviously we need to improve the survival, but we also need to improve quality of life.
Tell your immune system to be able to identify the cells that it should have been killing.
This is the story of your liver's fight for survival. Liver cancer. It's a silent storm, often building unnoticed until it strikes. In part 1 of this series, we explored the growing threat, how this disease has become more prevalent, and why the numbers continue to rise.
So, I think it's really driven by more obesity and more alcohol. It takes a long time to get liver cancer. We're just starting to see a spike in liver cancer from the Great Recession, like 2007. So you can imagine people started drinking more during the pandemic. I can't even imagine what my clinic is going to look like in 10 years.
Many Americans apparently drinking their way through quarantine. It's easy to chuckle about that, but it's not funny.
We looked at the science, the risks, and the harsh reality of what liver cancer does to the body.
Each year, there are almost 1 million new patients diagnosed with liver cancer. And prognosis isn't great. The reason why is because people usually show up to the doctor's office and they already have pretty advanced disease. The overall survival rate is low. So the 5-year survival rate is less than 20%, which means then less than 20% of people who get liver cancer are going to live beyond 5 years.
Worldwide, there's more than 700,000 people that die per year. And in the United States, liver cancer ranks among the top 10 killers, both in men and in women, although we know that men are more commonly affected than women. Roughly a little bit less than 50,000 people die in the United States every year from liver cancer.
For every number you hear in a statistic, there is a person behind the number. A mother, father, son, daughter, a neighbor, a friend. If the survival rate wasn't enough of a concern, the path to recovery from the disease is just as arduous. The cost of health for a patient is often very high and painful. Our team set out across the country to find individuals who have faced this battle, to learn more from their stories, so we can get a clearer picture of what this dark cloud society faces actually looks like. These stories will guide us along our path as we run into the unlikely heroes at the forefront of this fight and help lead us to the possible solutions on the horizon.
My mother just got diagnosed with HCC. She has numerous tumors. The largest is 1.8 centimeters in her liver. The doc said chemo is the option as the tumors are close to the portal vein. I don't know if chemo will be helpful. My mother's feeling so much pain in her right side of the abdomen, I can't see her in the shape.
I just found out my dad was diagnosed with HCC. The tumor is 7.5 centimeters, and there are multiple smaller mets inside his liver. I don't know what it all means. His first appointment is tomorrow at the cancer center, but his scans were done on May 2nd, so I'm worried it'll spread more. They're doing a chest CT too. I just found out yesterday. My head's spinning.
I went outside and just stood outside under the moon and just looked up at the stars and in the heaven and wondered how much more I could tolerate. Wondering how far I was going to get and feeling like this might be the end and really feeling not sorry for myself, but sorry for my family, and then also sorry for all my students that I was still in relationship with, my community at large. So that night under the stars, I did just lay down in the field in my bathrobe, cried really hard and said goodbye to the world.
These are the patients.
My name's Karen Hoyt, and I was diagnosed with hepatocellular carcinoma in June of 2014. In 2010, I was diagnosed with a liver failure. I had an emergency room situation where I was cycling one day, and the next day my liver failed, and I turned yellow and blew up overnight. Liver disease can be a silent killer, and we had no idea that my liver was failing until my organs began to shut down. So I had to have blood transfusions. It was just an enormous mass rush to save my life. And it was a pretty cruel blow to find out that then, even after I got stabilized, I would have to continue to be surveillanced or continue to be monitored for the rest of my life for liver cancer.
Cancer is very impactful on people's lives. We were talking earlier about the fact that there's nobody who hasn't been impacted in their life by cancer, whether it be a family member, a loved one, a friend. It touches everybody. It's a very frightening disease that in general people don't understand. They don't know really what cancer is, and it's because it's super complicated. Cancer is not one disease, it's a multitude of different diseases that are biologically distinct. Anybody can get it. Doctors get cancer, healthy people get cancer, unhealthy people get cancer. It strikes everybody.
So I had surveillance done every 6 months, just like my doctor ordered. I stayed in compliance with everything they asked me to do, and that included getting an alpha-fetoprotein marker, which is just for the type of cancer that I got. And I also had ultrasounds done every 6 months. And during one of my visits, a routine visit, my liver had popped a tumor.
Hi, my name is Jason Crutchley. I was diagnosed at birth with atrial septal defect, transposition of the great vessels, subaortic stenosis, and pulmonary atresia. Basically, I was born with one chamber of my heart instead of four. I had the Fontan procedure. One of the downfalls of the Fontan is the increased pressures throughout the body. Those increased pressures gave me cirrhosis of the liver and also gave me hepatocellular carcinoma.
About 80% of these cancers arise in the context of underlying liver disease and chronic inflammation, which makes it way more difficult because you actually have a cancer that arises in an already diseased organ.
I was actually being worked up for a transplant in 2017, and in 2018 I had gotten up in the middle of the night. I couldn't sleep, had insomnia, and decided, I'll read through my medical chart just to see what the doctors had written, kind of curious, and so I'm reading through it, and I saw a few things, and all of a sudden I'm reading hepatocellular carcinoma, and I went, wait, what? I know what carcinoma is. What is hepatocellular carcinoma? And it was 3 o'clock in the morning. It was in November, if I recall, of 2018, and I'm like freaking out. What is this? And so the next morning they called me up and said, oh, you didn't know?
My name is Florinda Gray Davis, and I was diagnosed with end-stage liver disease in April of 2017. I was diagnosed with inoperable liver cancer in August of 2017.
Cancers like to hide from the immune system. The immune system is constantly trying to fight cancer. Cancer is always hiding from the immune system. And one of the ways that the cancer hides from the immune system is it puts up these blocks on the immune system. The most important molecule that has been identified to date is PD-L1. PD-L1 on a cancer cell binds to PD-1 on a T cell. That's the immune cell that attacks the cancer. And it's basically a don't attack me signal. So it actually turns off the immune system.
I was running a high fever. 104 for an adult is not a good thing. And I remember being thrown back on the bed, doctors around me, really don't remember much, but I woke up in ICU. And this doctor comes in and he says, Miss Gray Davis, you have inoperable liver cancer and you need a liver transplant or you're gonna die. And turns around and walks out. And I look at my aunt and I'm like, what did he say? I said, what did he say? Go get him. And so she goes and gets the doctor, and the doctor comes back in, and I said, "What did you say?" And he said, "You have inoperable liver cancer, and you're going to die if you don't get a liver transplant." That was it. And
Steve Jobs said, "Knowing you're going to die changes everything. If you know you have a limited time, you want to make it meaningful." Mitch Albom from Tuesdays with Morrie said, "When you learn that you're going to die, you start living differently." But it was Seneca who said it best. Sometimes, even to live is an act of courage.
Since I've eaten anything, it's been a week since I talked to somebody. It took handfuls of painkillers, and also I was in off and on with a relationship with someone that was a cutter. Like, all right, well, if you're cutting, I'm gonna cut too, and slice my arm up real good.
It seems like we're going backwards. I mean, there are 22 veterans every day that commit suicide. That's over 8,000 estimated. 22 veterans a day. That's over 8,030 people annually that are taken from us. And if you look at that under any other demographic, it's a big deal. I mean, those are massive numbers of people that are no longer with us.
And of course, that's just the tip of the iceberg. 3.4 million Americans every year make an active plan to kill themselves. 1.7 million Americans every year actually try to. And they say 50,000 people a year die of suicide in the United States. We know that's the tip of the iceberg. We know that the majority of people who die by suicide, it's unreported.
I had a week of blackouts, and then that was the day that I woke up my last day and everything was a mess. And that was the day that I was in a guy's office, and we talked about this before, and I was prepared to jump out the window. I was on the windowsill, I was ready to go. And it was my mother's voice who said, suicide is selfish.
One of my closest friends, Mitchell Max, man who was at the very top of his class in Yale College, very top of his class in Harvard Medical School, came to me in 2009 and said he was having an episode of depression and just wanted me to be involved, wanted me to sort of be part of his team. I said, well, okay, Mitchell, you and I both know that this is nothing to trifle with. This is a disease that can be lethal. What are you going to do about it? He said, well, I'm going to go see the chairman of psychiatry at my university. Well, when are you going to see him? I'm going to see him on Tuesday. Will you call me after you see him? Yeah, I'm going to call you. Calls me up, says, the guy really understands me. He says I'm going to be fine. He gave me some Zoloft. He's going to see me in a couple weeks, but I'm not worried. So he winds up seeing the junior guy in the department who says, this Zoloft isn't working as fast as we'd like. Why don't we triple the dose and see what happens? Well, if you read the label on Zoloft, it says, caution, this drug may cause suicide. And sure enough, Mitchell goes home and hangs himself. And that's probably the most shocking moment of my life. It's probably the biggest surprise I've ever had in my life as a physician.
Like an organ like the kidney or even a complex organ like the heart, they're nothing in terms of comparison to the brain and the mind. I mean, we are still struggling at a very rudimentary level to try to understand how people's subjective feelings and the way they think can possibly be can emerge from a 3.5 pound piece of tissue with wires in it. It's just mind-boggling. But nevertheless,
the worst side effect from mental illness is the total loss of one's natural instinct for self-preservation, our very will to live. But from the ancient Greek tales of Lucretia to the star-crossed lover's fate of Romeo and Juliet, or even to the more modern, teen-spirited tragedies of people like Kurt Cobain or Robin Williams, mental illness and suicidal ideation are nothing new to the human condition.
Oh, you mean like croquet? Croquet!
In fact, the list of people you've probably heard of that face their own battles with mental illness and suicidal thoughts is longer than you may think.
It is for us, the living, rather to be dedicated here to the unfinished work which they who fought here have thus far so nobly advanced.
Abraham Lincoln long battled mental episodes that often led him to think of suicide. The playwright, Tennessee Williams, documented his struggles with manic depressive states in his memoirs. Virginia Woolf, the famous British novelist, Vincent van Gogh, Beethoven, Charles Dickens, they all had their own internal wars with either depression or mania. It was only until fairly recently did we even understand bipolar disorder as separate from depression. Even Sir Isaac Newton was documented as having symptoms of what was known back then as melancholia. But where did our first understanding of all this start? And how much has changed since the past and how we treat this?
In the early days, folks who were experiencing depression were labeled as something maybe that they weren't. They thought something was going on with this person, but they didn't really have a clue that it was this person is just depressed.
In the 5th century, the Greek physician Hippocrates proposed that depression, then known as melancholia, originated from an imbalance of the body's 4 fluids or humors: yellow bile, black bile, phlegm, and blood. He particularly associated melancholia with an excess of black bile in the spleen. His remedies included bloodletting, baths, physical exercise, and dietary changes. On the other hand, Cicero, a Roman philosopher and statesman, held a different view. He argued that melancholia stemmed from psychological factors such as anger, fear, and sadness. A prevalent belief among many, including the educated Romans, was that mental ailments were caused by demonic forces or the wrath of the gods.
Our theories have progressed. I think once we were able to identify sort of the brain, and you think it's obvious to us now, but it took many centuries before the brain was sort of identified as the focal point of emotions and thinking.
In the Middle Ages, mental health was heavily influenced by Christian beliefs in Europe, attributing mental disorders to demonic forces once again. This led to practices like exorcisms, and in harsher scenarios, drowning or burning the afflicted. Many were confined to what were then called lunatic asylums.
And to alarmingly recent history, folks were institutionalized against their will for sometimes their whole life. And it was largely due to the fact that we didn't know what to do with them. We didn't know how to help somebody who was struggling with depression because the research wasn't there. The knowledge wasn't there of effective ways of managing depression and helping somebody who's struggling with depression.
In the 18th and 19th centuries, or as we know it, the Enlightenment Age, melancholia was often seen as an unchangeable character flaw, believed to be hereditary. This perspective led to continued outcasting and institutionalization. As the Enlightenment Age continued, various theories emerged about depression's origins, ranging from internal conflicts between desire and moral understandings to searches for physiological reasons behind the disorder. Unique treatments of the era included prolonged submersion in water, using a spinning stool to supposedly reorient the brain, along with dietary changes, enemas, horseback riding, and induced vomiting. Benjamin Franklin even experimented with an early prototype of electroshock therapy during the time, which, believe it or not, is still a treatment used for treating bipolar depression today.
So, ECT, electroconvulsive therapy, is a treatment with a lot of stigma, but we do it a lot now in the clinic. It works quite well. It's the most effective treatment we have. It's probably the most effective treatment for suicide prevention in terms of psychiatric practice.
Big Biz Show continues. Hope you guys are having a great day. We certainly are. One of the reasons is because we get to listen to the Day Trader Trio every single show. Back here at the bar, it's Costa. It is how we fund. And of course, it is solar.
I want to see what happens when Bitcoin turns into Ethereum. Bitcoin, in my mind,
is an investment vehicle, something to invest in, like a piece of real estate, like a share of
Digital
Apple.
gold is a great analogy.
But Ethereum is turning into a financial base. And I think that's interesting. Here to talk about that, Charles Allan. Charles Allan is the CEO and chairman of the board of BTCS Incorporated, their ticker symbol BTCS, and he joins us for the first time right here on the Big Biz Show. Actually, Charles? Well, for the first time with you. Charles and I have a history together.
Are you serious?
He taught me about Bitcoin and Ethereum and everything else and why Ethereum matters. Right? Do you remember those conversations, Charles?
That was like 7-8 years ago.
Yeah, right. No, I have to tell you, and it's so great to see you again because everything you said was going to happen. And I thought, do I get this guy back on the air so he can rub my nose in it, or do we let him take a victory lap? But it's fantastic because Ethereum does matter. It's the new financial internet. Talk about what I was just saying. When I think about Bitcoin, well, this is how I think about this. First of all, we're all in the world of digital currency. We all have the same $40 in our wallet. Unless you've tipped somebody, you haven't used your cash for the last 6 months. Number two, there is this blockchain that makes things more, I think, efficient and fraud-proof. But then you've got the currencies and the tokens and everything else behind it. I think what's interesting in this world is that you've got an investment vehicle, but you also have a financial tool. And not since the dollar have you seen something like that. Talk about, I'm going to let you take it away from here, Charles. Talk about what's going on in that world and in your world.
I mean, I couldn't agree more. And we pivoted to Ethereum a little over five or 6 years ago. And as much as I love Bitcoin, it doesn't do much. It's just a store of value. When I look at Ethereum, it allows for the tokenization of real world assets and a movement of those assets over the internet on a global basis with no intermediary. And that is remarkable. And that's what the internet did for information, 20 plus years ago. Before that, you got newspapers and magazines, and then, the internet brought the proliferation of information on a global scale. And, 25 years later, we're going to do that with assets, and that's going to be built on Ethereum. And so I think that's a fundamental change in how society is going to work. It'll primarily be the back end, but that's really revolutionary. And we're seeing it with stable coins that are built on Ethereum, with all of these other DeFi protocols and products and services that are going to really change the way in which we interact with each other. So it's a pretty exciting time. And we actually have a regulatory framework where you can do this without fear of the government. And so that's really new. That's 9 months old.
Yeah, Charles, pleasure to speak with you. Can you talk a little bit and expand on that and kind of tell us how important it is that Ethereum is going to be regulated as a security versus Bitcoin as a commodity, and then some of the capabilities that you're going to have? It's the second largest cryptocurrency behind Bitcoin, and you're going to be able to help tokenize liquid assets, private assets. I mean, can you talk about some of the applications and then what the better securities law will do?
Well, securities law is huge, right? We by way of example, we've held Ethereum for 7+ years, and the FCC would consistently ask us if it's a security, right? Tell us why it's not, and then they wouldn't allow us to raise capital or access the capital markets. Now they've kindly come out and said it's not a security, and that's a really huge win, because if something's a security, you have to comply with all these laws. There needs to be an issuer. Well, how do you have an issuer that's a decentralized protocol? It's an impossible law to comply with. And so now that we have regulatory clarity, it means large institutions that sat on the sideline that said, hey, this is amazing technology, we can rebuild on this technology how the financial infrastructure works, whether that's NASDAQ looking at blockchain technology or Fidelity or BlackRock. All of these companies were afraid to build solutions on top of a protocol that the government was unclear about and was more likely than not a security. Now that it's not a security and it's just a technology stack with the underlying token being a commodity, it really opens the door for huge capital inflows and huge development. And I think that's really recent, and we haven't even seen that really reflected in the market in terms of the price of Ethereum.
Can you just kind of break us down on DAT?
We actually pioneered this, going back, and we've been public since 2014. So we were the first ones to have a digital asset treasury strategy. And then I think that the one everybody knows about is MicroStrategy. And really the concept is you take a cryptocurrency token and you put a public company wrapper around it. And what that does is it allows access to that underlying asset through the public markets, which is much easier for retail investors. It's easier if you hold, if you hold stock in a 401k. It's very complex to get that into crypto. It's getting easier today, but you have to manage the keys. You have to have a wallet. There may be tax implications taking a withdrawal. Institutions may have restrictions on what they can invest in. And so once you put a public wrapper around something, and it's not an ETF, because a lot of hedge funds aren't allowed to invest in ETFs. It's, you're getting paid a management fee to make investment decisions, not give it to another manager to just hold a single asset. So putting a public company wrapper around a crypto token opens up a lot of doors. It allows for a broader investor base. It allows for you to put leverage on the company. And if it's not an ETF, you're not a 40 Act company, you're an operating company, it allows you to actually have an operating business. And so that's the high level strategy. There's, dozens and dozens of these digital asset treasury plays. I think there's, 30 plus for Bitcoin. I think there's around, close to 10 for Ethereum. And then there's a couple on Solana and all the other blockchains. In the long run, though, I think the value of a company that has digital asset, treasuries, that really isn't going to need to come from the operations.
I think this Ethereum dividend that you have is kind of a good kick in the pants to either cause a short squeeze or defend against shorts. Do you want to explain how that works? Am I accurate in saying so?
No, you are 100%. We actually did this in 2022. We were trading below our liquidation value or book value, or what they're calling now MNAV, about a 20% discount. And we kind of scratched our heads and said, this is ridiculous. We saw high short interest, so we paid the first ever dividend in Bitcoin. It was 5 cents a share, similar to what we're doing today in Ethereum. And that was kind of when we were exiting Bitcoin, so it was a good way to kind of unload it. And it was really interesting what happened when we did that. First, if you're a public company and you say you're going to do a dividend, NASDAQ has to give you an ex-dividend date. So you set the record date and they have to announce the ex-dividend date. Well, they wouldn't do that initially. So they said, nope, we want you to talk to DTC. So we talked to the Depository Trust Corporation, and they said, we don't really like the way you're doing it. I talked to 20 people. And then, a week later, I said, well, we'll think about what you said, the way you want to do it. And we came back to them and said, no, we don't like that. We can't KYC our investors. It creates risk. We're going to do it our way. And they said, well, we want you to have a call with our participants. So I got on a call with 140 people. I took screenshots of this. This is crazy. 140 people. I think it was every back office of every brokerage firm. And basically what they told me was there's 4 people that raised their hand and asked questions. We had NASDAQ and DTCC there. And 4 of them asked the same question in different ways. They basically said, well, what if we've hypothecated and rehypothecated the shares? And my only thought was, well, that seems like that's your problem. If you've made up shares and let them out, it's
I think they call that a derivative.
So I think what was it saying? Like in crypto, it's not your keys, not your coin, right?
Yeah, right. Sure.
Private keys, you don't own the crypto. And we've seen what happened with Mt. Gox and FTX. And in the stock market, if it's not your name, it's not your stock.
Right.
That's simple. And so what happened with that dividend, and this is, years ago, when NASDAQ finally announced it, our stock traded $500 million in one day, went up about over 100%, I think peaked at about 140%. There's $250 million worth of failures to deliver. And we were a 30 million market cap at the time.
Yeah, right.
I mean, it made no sense. And now we're trading at a 35% discount to our book value. So we actually have more value in liquidation despite growing revenue, growing operations, in a vibrant business. And we had not the most recent FINRA report, but the one from prior to that was 14% of the public float was sold short. We've had hedge funds sniffing around our ATM. And so we basically decided, hey, let's do this Ethereum dividend again. We'll do 5 cents a share. But we realized the first time we did it was a bluff, right? We bluffed the market, and they went and covered all their legal and illegal positions. We don't know what was legal versus legal, but there was definitely a lot of shorts outstanding. And the stock went up a lot. I think we raised about $10 million on the ATM on the back of it. And so this time we're like, well, we can't play the same hand. We can't play the same bluff. So let's just pay people 35 cents to get their shares out of street name where they can no longer be loaned and bring them over to the transfer agents, kind of like a game of musical chairs. And we'll see how it plays out. If If not a lot of people move their shares, nothing will happen. I would say best case scenario, if every single person moved their shares and our stock continued to trade, I've got a massive, I've got a smoking gun I can go to the SEC with, and I can have a big lawsuit.
Exactly
if
right.
More shares short than are in the public float, again, there's
spoofing, counterfeit shares. There's lots of stuff we can do about it. 100%. That's for sure.
100%.
We got to get you back, man. We need you on a regular basis. I'm telling you, we're not going to. You're in the mob now. We're not let you out. That's right. Charles Allan, Chief Executive Officer, Chairman of the Board, BTCS Inc. Ticker symbol BTCS. Big Biz Show continues. If you're wondering where we are inside the Loft 100 studios in beautiful, sunny Southern California. Thanks everybody for being along for the ride. That's the Day Trader Trio. They're always along for the ride. And of course, back here at the bar, it is Costa, it is Mary Bird Godwin, and it is Sully. I'm excited to talk to our next guest. Our next guest was a regular a long time. Good guy, really good guy, and a really interesting company. He is Dr. Waqaas Al-Siddiq. He is the CEO and founder of TriCity Incorporated. Their ticker symbol is BTCY, and we welcome him back to the Big Biz Show. Doctor, it is great to have you on. Welcome back after a long, long hiatus.
Hey, nice to see you again.
Good to see you. Hey, catch us up on the business of saving lives, because that's what you call it, and you always called it that. And I thought that was the best part about a biopharma biotech company is that's in the space. And you guys really are a technology company, also. Talk about that.
Yeah, no, we've been growing really well. We've now expanded. We're in about 35 states now, servicing 2,500 cardiologists, doing about a couple 100,000 lives a year, and helping them avoid heart attacks, helping them avoid strokes. We've also gone in and launched a consumer product which is now available on Amazon, so people can get that and actually manage their heart condition after they've been diagnosed, or if they feel that they have an issue. So there's a big push on longevity, so we're trying to make clinical technology accessible to everybody.
You talk about what 20 million adults live in the U.S. Are struggling to afford health care. And you're sort of decentralizing it with the device on Amazon. I mean, that's the first thing I thought, and that's only a piece of the puzzle here.
Yeah, no, absolutely. We've essentially, democratized and provided access. I mean, one of the big things is that in healthcare, like, there's been a push to services, where people are providing services, and what they're essentially doing is they're taking dollars away from hospitals, dollars away from clinics. So when you have that 3-month waiting list to see a cardiologist, it's because the approach in the marketplace has been to provide a service. And what we've done at TriCity is we're saying, okay, let's be an enabler, right? Let's enable everybody. Let's enable the consumer. Let's enable the doctor. Let's enable the hospital. And so we're putting dollars back into the hospital system. We're putting dollars back into the clinic so that they can service more patients. And then we said, well, we're not going to stop there. We're going to take that technology and make it available for the consumer as well.
Dr. Waqaas Al-Siddiq is the CEO and founder of TriCity Incorporated, ticker symbol BTCY. Doctor, talk about the HeartSecure device and the in-home test that people can easily get hold of and easily do.
Yeah, absolutely. I mean, one of the things that we recognized were that people would start calling us and they said, can we get access to your technology? And we're like, well, it's prescription based. So, see if there's a doctor near you. And some of these patients are rural, right? They don't have access, or the wait list is 3 months. We just had a recent person that called in and they wanted access to the technology because they were going to go in for heart surgery and they wanted a secondary check afterwards. So, one of the things is that you can go to your primary care, you can get a referral. And so what we did was we created HeartSecure, so anybody can order it. We've got a cardiologist on staff. They will prescribe it, and you can pay for it for less than what you're going to pay for your copay, and the cost it'll take you to go through multiple channels to get that report. So providing that accessible for private pay opportunities, but also go to your cardiologist and get it insurance reimbursed. So we're trying to service everybody, and really it's in response to the demand that's coming in.
Absolutely.
Doctor, can you tell me, how is the device? You wear it around your chest, you wear it on your body. How does it work at home when you use it?
Yeah, great question. So, a lot of people talk about the Apple Watch. to get your ECG, you have to go across the heart, and so our device sits right on top of the heart. That's why if you try to use one of those smart watches, you actually have to hold the watch, and most issues happen while you're sleeping. So for a consumer product, we have a wearable strap that you'd wear underneath your shirt. If it's a diagnosed product like Heart Secure, you're gonna wear it right on top of your chest, and it's got 3 little stickies that you wear. And if you want to, like I said, long-term use, you're going to use it as a strap, so there's no stickiness. And that's the 2 modalities that we've created. One, to support long-term care, because cardiac disease is progression, right? It's a progressive disease. And for those who are just using for diagnosis from a cardiologist or for 5 days, they can just wear the monitor and then return it.
So don't think of my Apple Watch as my cardiologist, is what you're trying to tell me.
And who are the people?
No, I mean, it'll recommend you to go to a doctor, and then they'll use a device like ours, right? So the question is, it's a stopgap, right? It's great for awareness, but ultimately you need something that's clinical, and that's why we're always trying to deliver, and that's why we grow every year.
That's amazing.
There are times when I think, oh gosh, what's that pain? Oh God, what did I feel?
Oh, my left arm's numb.
Such a hypochondriac. So to avoid that,
it's not the professionals I'm concerned with; it's the experts. And and the minute you try to self-diagnose, you go to WebMD.
Can I have one just to have at home?
And suddenly you've got Lou Gehrig's disease or pancreatic cancer.
Yeah,
I mean, it's the top 2. So how do you avoid that sort of misdiagnosis by going to the University of Google or Perplexity.com and figuring that out? I mean, obviously, there's plenty of disclaimers on to go to a doctor, but your stuff's pretty foolproof, and it always has been.
Yeah, no, absolutely. I mean, that's what we've been trying. Now you got ChatGPT, which is like, everybody's personal MD. I think that creating the access is what we try to solve, right? And we're bringing in the clinical people that review the data. So at least you have something to act upon, right? So if you really are worried about it, or you got that numbness and you're saying, hey, you know what, my loved one had a cardiac issue recently, so it makes you, go online and look, and you're like, oh my God, I have these symptoms. Well, before, you'd have to go to your primary care provider, request a cardiac study, wait 3 months and do it, versus, hey, you can go online and you can either order our monitor off of Amazon, or you can order the clinical report from Heart Secure, and it gets delivered to you, and you can at least get a cardiologist review. So you skip the line, but at least you can do something about it.
Hey, Waqaas, are you focusing on wearables, or are you focusing on the med industry, or both? Or is that a yes to both of these things?
Good question. I would say that our primary focus is really the healthcare providers, right? The hospital healthcare providers, the cardiologists, and the providers. What then happens is that there's an access problem. There's not enough cardiologists, right? You've got 20 million Americans diagnosed. You got 70 million at risk. You got 33,000 cardiologists. It's just not a sustainable model. And so we've created the wearable market, and we've created the access point, but it's not our focus. It's there because in response to inbound interest, we've made it available to everybody. But it's not something that we're pushing as a company, where if we had to spend our marketing dollars, where do we spend them? We spend them on capturing the clinical market and the hospital market, because we know that those patients are the sick ones that really need it. Yeah, right. And for everybody else, it's available.
Well, and the point is that even though it is a global wearables market of about $85 billion, you get a lot of traffic there too. And a lot of that's not only Fitbit and Whoop and Oura rings, but it's also a T-shirt that'll measure how much perspiration you have and your acidic base on what you're eating, so on and so forth. Well, Waqaas, we got to get you in San Diego. I'd love to have you in studio at some point. We can teach for a whole hour. I hope we get to have you more on the air. Dr. Waqaas Al-Siddiq is the CEO, founder of TriCity Incorporated. Their ticker symbol BTCY. Yes, you will see a lot more of him on this show.